The broadcast is now starting. All attendees are in listen-only mode.
Good morning to everyone, and I hope you are having a great start to your Friday so far. We're almost there to the weekend. Thank you for joining us again for another safe and calm COVID-19 webinar here with Leading Age Michigan. Before we can get started, I did just want to mention one thing. Leading Age Michigan would like to extend our sincere appreciation to all of our generous business partners who have continued to support us and our annual conference despite it being temporarily postponed. We look forward to continue our collaboration and we remain grateful to you. Just to name a few of those organizations that have stuck with us throughout this part and are still registered to exhibit at our upcoming annual conference once we set that date. We have 360 Care, Advanced Satellite Communications, AllMed Medical Supply, Basic American Medical Products, Compass Communications Group, Concept Rehab, Dermarite Industries, Easy Way, Fox Rehabilitation, Functional Pathways, Furnishings by Design, Fusco Schaefer and Papas, Genesis Rehabilitation Services, Health Pro Heritage, Hookstra Transportation, Hometown Pharmacy, Hooker de Jong, HPS, HPSI, In Touch Pharmaceuticals, Interstate Restoration, Kalamazoo Long-Term Care Pharmacy, Marcus and Milchap, McKesson Medical Surgical, Midwest Juice Group, Mobile Care Group, Pharmerica, Point Click Care, the ProSure Fund, PS of MI, Reliant Rehab, Select Rehabilitation, Spartan Chemical, The Compliance Store, and TMC, which is another therapy management company. Obviously, if you have any questions, we will read them out and we will take breaks throughout the presentation as we have for all the previous ones. Now, I think that covers everything that I needed to take care of. So now I will turn it over to Deanna Mitchell. Thank you.
Thank you, Blake. And good morning, everyone, and welcome to another Safe and Calm program webinar. This week has been very busy. As you can tell, we had to postpone the webinar. And it seems like the problems and issues confronting us seem to be more and more complicated every day. We know that you all continue your hard work on the front line and are likely growing weary. And yet it seems to be that this will be a really long process for everyone, and especially for those serving our frail seniors. So we thank you for the work that you do every single day. Today we will work again through our standard agenda, and we'll do so within the context of the political issues that are here in Michigan and at the federal level. This morning, the legal suit about the governor's powers went before the courts, so it'll be interesting to see what happens with that. And the question, of course, of when to open businesses continues to be debated. This morning, we're going to start, as usual, with the situation summary, the COVID statistics, and then we will rely on Dalton Herbal to discuss the recent Leading Age Michigan advocacy. Laura Funch will be joining us to discuss recent trends from the SNF infection control surveys, and we will finish with our usual guidance and other updates. So moving on to our first slide about the statistics. It demonstrates, and this is a slide that I've often used, the number of days that it takes for cases to double. And the United States, as you can see here, has a high number of overall cases, but also the curve continues to go up. It's always going to go up because the cumulative number of cases can't do anything else but that. But the curve has looked similar to this for many, many weeks. And I would say about a month ago, we were just on the other side of doubling our cases every 5 days. Now it looks like we're probably close to about 6 days. So although there are areas of marked improvement in the United States, overall it is slowing, but I wouldn't say that we're really over the hump yet. Then when we look at the number of deaths, and this is a slide again that I've used before, you can see a decline in the 7-day rolling average of deaths. So that's a very positive finding. The proportions though remain pretty much the same, with the United States accounting for about 30% of average global deaths. And I think this is through May 12th, yes. So this slide has progressed as we put it on here. Those numbers and the width of those colors at the far right have decreased, but it's still, of course, a significant number of people obviously are dying. So moving forward, if you look at this updated map as of yesterday, it looks very similar to our other maps as well. This map identifies who has stay-at-home orders and the actual number of deaths in each state. And you can see that the circles, which characterize the amount of deaths in each state, still pretty large for Michigan. Compared to other states, at one point we were number 3 in the raw number of overall cases. We've been floating around number 6 for several weeks now. As of May 14, and these are nationally reported numbers, I didn't get these from the state, we were at about 49,000 cases. And the number of cases, though, per 1,000 population is a little high for Michigan. You'll see that Illinois has fewer cases per population. And of course, California has a lot fewer. Our death rate tends to be a little high still as well. This next slide comes from the Michigan Department of Community Health, and it demonstrates the daily confirmed cases against the ever-growing cumulative number. This data is raw data, therefore it's not smoothed for the ups and downs in testing or reporting. You'll note that there is a huge blip upward on May 14th, which was yesterday. But that is due, and I think that most of these up and down waves are due to the way cases are batched and reported. It doesn't necessarily mean that more cases occurred yesterday. So because of that, you really have to look at the smoothing this data out a little bit to see where the real trend is. So this slide, and these next 2 slides are slides that I'm reporting on a daily basis, shows the 7-day rolling average of daily Michigan new cases from April 1 through yesterday. And you'll see that blip. I mean, that blip does occur even though, this data is smoothed out a bit. But if you look at it, you will still see an overall downward trend that continues to be fairly positive. This slide shows the number of Michigan new deaths. Again, the same thing. This is a 7-day rolling average. Therefore, the data is smoothed out a bit, and definitely good positive trends downward. So this week, as we talk about advocacy, I have to say that there have been times when we have been booked, double booked, and sometimes triple booked for meetings with legislators and policymakers. And to discuss a lot of those conversations, I will turn the presentation over to Dalton Herbal, our Director for Advocacy, for a summary of this week's activities.
Good morning, everyone, and thank you for attending today. I just wanted to remind everyone that the handouts are available in your GoToWebinar panel. I do have some links in here that link to some resources for those who are interested. For today's call, we're going to be touching on 4 things. The first is the HEROES Act, which is that next part of the COVID stimulus kind of ongoings that are going on at a national level. We're going to touch on the conversations and kind of the updates around what's going on in the state regarding legal immunity protections for healthcare providers. And we're going to be touching on the most recent numbers that came out of the budget update material. If you've been attending these webinars, you'll know that most of the legislatures were waiting for April to hit in order to have solid numbers, and April is behind us and the numbers just came out. So we'll touch on those. And lastly, Deanna will touch on Executive Order 2020-50 and the regional hubs and dedicated units. As Deanna mentioned, we were double and triple booked. On Wednesday, for the exact time of the webinar, so we apologize for us having to reschedule, but we certainly appreciate all 75 of you attending today. First, I made a slight error with the format here. That top should say the Health and Economic Recovery Omnibus Emergency Solutions Act, also known as the HEROES Act. These are just some general large picture points regarding things that the act has in it. Firstly, it's a $3 trillion stimulus package unveiled by House Democrats. The Senate at this time is not interested in passing it as is, and debates will be ongoing with that, and we'll touch on those debates a little bit when we talk about legal immunity protections on the federal level. In the package, there's $500 billion for state and local governments, a $200 billion HERO fund to ensure that essential workers will receive hazard pay, $850 million for states to provide child and family care for essential workers. It extends the unemployment actions they took underneath the CARES Act, $75 billion in additional testing and contract tracing and isolation measure resources, $100 billion in emergency assistance to low-income renters and for low-income housing, and a second round of direct stimulus payments and checks for Americans. And there's also some money in there to assist the Postal Service as it struggles to find funds during the COVID pandemic. And that link right down there is a link to the actual language of the bill if you are so inclined to read it. It is quite long, so I would recommend you wait for Leading Age's summary to come out this Friday, and that's Leading Age Nationals. They've been doing a great job on their webinar covering it in a 3-part series. For some interesting points for long-term care that come out of the HEROES Act, the HEROES Act halts U.S. DHHS from finalizing or implementing the final stages of MFAR. That would essentially cut $50 billion from Medicare. I think it's Medicaid. Anyway, it would essentially cut $50 billion, and by not implementing those, $50 billion would be saved for long-term care providers. It raises the FMAP percentage by 14%. It allocates $500 million for states to create nursing home strike force teams. Right now, these teams are slated to help manage outbreaks in communities. So I know there's always some hesitation when you hear of a nursing home strike force team coming into your building, but right now they're just supposed to help manage the outbreaks. And there's $210 million for Medicare's quality improvement organizations to assist with infection control practices. Leading Age National also provided a specific housing summary, which is linked here. It is great. And if any housing providers are interested, I highly recommend it. It's a quick read and a really good summary. Some highlights from that summary include $500 million for Section 202 providers. And of that, 300 of that is used to expand the number of service coordinators, and 200 million of that is used to reimburse Section 202 providers for COVID-related expenses. There's also $750 million for Section 8 project-based rental assistance. Moving on to legal immunity, as I mentioned, there's kind of a weird coalescence going on right now between the HEROES Act and legal immunity. The United States Senate has made the inclusion of legal immunity for healthcare providers one of their key asks in their negotiations for passing the HEROES Act. We'll see where that goes from now. That was relatively recent information, so we'll see where that goes. On Wednesday morning, Leading Age Michigan submitted testimony to the House Judiciary Committee. We were there in person to testify. The committee had to run short, however, because the arguments for and against the bill got rather heated and representatives had a lot to say. Our language explicitly added adult foster care and CCRCs to the list of covered entities for immunity. We're hoping to still see that pass, and we're still working with the chair to get that done. As I said, a lot of the concerns from representatives were stated at the hearing. Their main concerns were that the liability protections were too general and offered too large of a blanket. and that healthcare providers would not be held responsible for the provision of PPE to their staff. And because of these concerns and concerns of healthcare provider associations such as us, the hospitals, and pretty much any healthcare provider association out there right now, progress has been slowed on the bill. Initially, we thought it was going to move this week. It's looking more like it's going to be moving next week as they continue to work on the provisions in the bill. Many healthcare providers and other provider groups want to add people to the liability protections, and many representatives are concerned that the protections are too general. So it's kind of this delicate balance that they're still negotiating, but we're hopeful something will get passed next week. Moving on to the state budget. As you know, we've been waiting for this April data to come out so we can actually get a more accurate number. Today is the State Consensus Revenue Estimating Conference. That is where Senate Fiscal and House Fiscal join together to actually put a pin on this is the number that we have facing us for the next fiscal year, and then they can forecast from that point. Early estimates before the conference pin us somewhere in a budget deficit of $2.6 to $2.7 billion. And that's about $1.4 billion in the general fund and $2.1 billion in the school aid fund in a deficit. I have seen numbers that go as high as 2.7. I've seen low as some as low as 2.5 billion, but either way, it's about $2.5 billion. That's a very, very large hole that they're going to have to look to fill. There are similar estimates for the next fiscal year. Right now, they're pinning those at another $2.5 billion hole for the next fiscal year. April income tax revenues are down 53.1% over April of 2019. April sales tax revenues were down over 30% compared to 2019, and 1.3 million Michiganders have applied for unemployment insurance benefits. This, in the next couple slides, I included a couple charts that the Senate and the House fiscal agencies put out that I thought really demonstrated the overall state of where Michigan was in a nice format. Right here, you can see the most current fiscal year compared to the last fiscal year on this chart. And then you can see the difference in major state tax revenue that the state received. So as you can tell, the fiscal year starts in November for 1920, which is that dark blue, and the white represents the difference in received tax collection between 1920 and 1819. And as you can tell, for April, the state collected about $1.2 billion less in major state taxes. Since we lived in Michigan, I thought this would be an interesting slide to show everyone. As we know, Michigan is the automobile state, the automobile capital. And this slide shows the forecasted auto sales for 2020. In 2019, there was 6.9 million light vehicles sold, and they're forecasting in 2020 because of coronavirus, we're going to lose about 4 million in auto sales for light vehicles at least. And that is a pretty drastic reduction. And as you can tell, they don't expect us to rebound in terms of auto sales until 2022, which is a theme we're hearing throughout the legislature, that they expect the next 2 years to be kind of rough in terms of budget, and that in 2022, we might actually be back to a place where we were before COVID occurred. So what now? As I just touched on, the legislature and many people are forecasting that we won't be back into the same place until 2022. The Revenue Estimating Conference today will trigger the Treasury to start to pull together the data for the governor, which will then allow her to propose her new budget and her new budget recommendations based upon the April data. At that point, the negotiations between her and the legislature will begin. They are still aiming to get this done quickly because many industries are already into their fiscal years and already missing funding. Leading Age Michigan and well, really just us, are actively working with the department, legislature, and governors office to make sure that the dollars that go towards care at the bedside stay at the bedside, and that the reductions aren't taken from those buckets. Lastly, I just wanted to reach out to all our members and let everyone know that there's a lot of confusion out there around what is going on in long-term care. What is long-term care even for some people, and how are you handling the COVID pandemic? Many people are receiving a lot of information from a lot of different sources, many of which don't always have long-term care's best interest at heart. We are asking and urging you to, if you have any relationships with a local legislator, please reach out to them, as you are the best resource for them. If they get any questions, a lot of them are getting a lot of constituent feedback right now regarding a large variety of things, and they need our expertise and guidance. And I think our members are truly the best resource for long-term care. If you want help or just want some contact information for your legislator, please feel free to reach out to me. You have my email there. Once again, thank you for listening to me today, and I believe Deanna is going to be speaking about Executive Order 2020-50 coming up.
I thought, Dalton, that we would take questions to you first.
Okay, questions first then.
All right. I do not have any questions for Dalton, but I did just want to address, I've had multiple people say that the link for the handout is not working. So we are sorry about that. Not sure why that isn't working for you. I can try to maybe throw another file on, but as always, I would say either today or very early next week, we will be sending out the PowerPoint along with the recording of this entire webinar and then the Q&A. So you will end up getting the handouts, and I'm sorry that the link isn't working right now.
Okay, well, if there are no questions, let's move on. I would like to talk a little bit more about advocacy, and especially about our advocacy and the ultimate dilemmas that we find around Executive Order 2050 that has now been extended only for a week through the issuance of Executive Order 2020-84, which is an exact replica of 2020-50. So when this was first issued, I was actually somewhat encouraged. It appeared that, although I felt that there were some conflicting messages in it, but it appeared that the department was going to support the development of regional hubs that would be well supplied, well staffed, and all set to serve our COVID positive patients. And that other facilities who had COVID positive patients would have to serve them in dedicated units, but if they didn't have a well resourced dedicated unit, that they would not have to take care of these patients under what I would consider poor circumstances. So I thought that that was kind of a positive thing. There were pieces in this that I wasn't sure of the language. This is a kind of a summary of the entire set of provisions in 2020-50. The first one that undid me a bit was you can't evict for non-payment nor deny resident access. And I still don't know what they mean by deny resident access. What kinds of residents, what kind of access, there were no descriptors around that. And all along, CMS and the department have stated that nursing homes and other entities could not wait for negative testing for admissions or readmissions from hospitals in order to keep those precious hospital beds open. So all types of residential facilities, not only just nursing homes, would have to accept anyone back who discharged from any other setting in this EO as well. So if you went home, facilities would have to take you back. I don't understand why that would be, and I also didn't understand the point of that. However, that's another piece that pretty much has, I think, fallen by the wayside as we try and figure out what they're going to do next. Have to facilitate telemedicine. That's something that we've heard in many avenues. So the main message under the protections for residents was this idea that all communities have to take all residents, whether COVID or not, and whether tested or not, which didn't seem like a safe situation. But then later, when we get to transfers and discharges, it seemed like, well, but there's going to be these regional hubs, and they're going to be able to take care of these patients, and they're going to be well resourced, and they're going to have great infection control practices, and that would kind of take care of it. And other facilities would have these dedicated units. So the reporting requirements were established in this executive order as well, and they pretty much haven't changed. We do know that they have only applied them to skilled nursing facilities so far, but we do also know that they're going to apply them to other levels of care very shortly. And in fact, there are plans in the work to do that. One of the requirements under transfers and discharges was that any nursing facility with less than 80% occupancy must have a dedicated unit. And that seemed absolutely unrealistic to me. And one of the problems that I've had all along is that their thinking assumes that all facilities are created equal in terms of staffing, skills, and resources. And in fact, we know that facilities with low occupancy levels tend to have fewer resources and more quality problems. So it just made sense to me that we needed dedicated units. I would prefer regional hubs, but that the idea that all of these other facilities who have low occupancy levels would have to create a dedicated unit never made any sense to me. So since that time, we've been having been told by the department that they were going to issue guidance on what was required for a dedicated hub, and a dedicated unit, and they have yet to do that. So overall, this guidance has been really, really difficult for me, and I know difficult for our members. We have gotten a lot of questions about it. We ask a lot of questions to the department, and they really have been kind of silent about it moving forward. On Wednesday, the department was questioned fairly hard about the overall decision to allow any admissions of positive COVID patients into nursing homes or other settings with uninfected populations. But at the same time, as they testified before one of the legislative committees, there was no movement on their part in any other direction. So we could not see any inclination to change their thinking about this. And when they were asked about why they didn't use alternate care hospital sites, which were effectively not needed in the long run for hospital surge, they said that they were concerned about transfer trauma for these patients, that moving people from nursing homes who were positive to these alternate care sites would be too difficult, that there were some structural issues about how to serve them in that physical environment, and transfer trauma. So to be honest with you, I felt that wasn't a very compelling argument. So our advocacy to the department centers on several areas, and you can move the slide forward, Blake, please. So first, we had some concerns about the criteria for regional hubs. When we checked this data last on Monday, we found that 7 facilities out of 19 carried an overall star rating of less than 3, which is average. We also found that 12 facilities had less than an average finding on their health inspections. In other words, they were under 3. So these are not average facilities. These are all 1- and 2-star facilities for the overall CMS star rating, their health inspection star rating, and then, of course, last but not least, there were 6 facilities which had less than a 3 in staffing. And then the thing that really kind of blew me away is that one of the facilities on the list, as of Monday, I do know there's a lot more facilities on the list today, but I have not looked at them yet. was a special focus facility on the CMS website. So I guess I have a real concern about what the criteria was for these regional hubs. And it appeared that these facilities were chosen after phone interviews, and while there are some set criteria for participating, it's not clear how well this is being tracked or monitored. Considering the number of deaths in our long-term care facilities and the development of the commission to study COVID growth in nursing homes by the White House, the projected continuation of COVID spread, especially among seniors, it would seem to me that we should be using these facilities specifically dedicated and well prepared to serve this population. And I'm, to be honest, not sure that we're there. So we've also commented on the apparent coordination issues between different state government agencies in Michigan. We've seen inconsistent guidance come out, and it's very, very clear that the communication and decision making is kind of garbled. And in fact, I just got off a call with the testing work group, and that was pretty much further established by that call. We're going to talk about that a little bit later when we talk about testing. So at times it feels like the entire plan has been built by a committee with only limited leadership driving the path forward. So we understand the resident rights issues. It seems that the very language in 2020-50 conflicts with what is needed to adequately serve the COVID patients. Residents have the rights to be in and return to the residence that they choose, but only in dedicated units and regional hubs can serve the population according to that language. I think the department has backed off from that, but the expectation is pretty much that every facility has some sort of dedicated unit. That's what I'm hearing now. Whether or not you have the ability to structurally do that, or you have the staff, et cetera, somehow or other, you're supposed to develop this dedicated unit. There have been so many, go back, Blake, please. There have been so many directives, and many of them mirror the CDC and the CMS guidance, but they vary in Michigan just enough to make our members a little confused. So as we're trying to figure out what the guidances are, it would be better if they align themselves, I think, a little bit better with the federal directives. And last, but certainly not least, in these dedicated units and regional hubs, we believe that COVID positive patients must be served in those facilities that are staffed, skilled, and resourced to do that. And at this point, at least I am not 100% comfortable with that. 2020-50 expired on 5/13, and we were expecting an updated version that was a bit more coherent. So we're quite surprised when yesterday morning they simply reissued it. However, since it's now been only extended for 1 week, we believe that there's an update coming. But the department has been pretty silent about their thinking about where they're going to go and if they've changed the direction at all, which I've not heard. I did hear that last night all of the major departments met and tried to figure out a picture going forward and debated some of the issues about whether or not to cohabit COVID positive patients with non-COVID positive patients, and some other issues about residents' rights and testing. But the last I heard is that they haven't come to any conclusion about any of that. So right now, before we move on, any questions about 2020-50, and it's now called 2020-84?
All right. So I have two questions. The first one is, what's the potential impact on members of the General Assembly blocking an extension of the PHE?
The General Assembly blocking, to be honest with you, I don't understand what that means. Can someone clarify that a little bit more?
All right, I'll move on to the next one while they maybe type that out.
I can offer a little explanation. I don't know the exact consequences, but the PHE is the public health emergency, I believe.
Oh, okay. Oh, okay. PHE. Okay. Oh, well, I think that there's huge implications to that. Considering what's going on in Wisconsin, I'm not sure how this will all play out. I think that everyone's up in the air. um, I can't imagine. I can't imagine it. So I guess we're just going to have to wait to see what the courts do.
All right.
Go ahead, Blake.
Are there Medicare CPT and ICD-10 coding that can increase a NCF's reimbursement for caring for a resident with a COVID-19 diagnosis?
Not that I'm aware of. I would have to look into it in particular. I don't believe the system has been designed to increase your payment just through that diagnosis. But let me ask someone who is an expert in that, and we will answer that in the Q&A.
All right. Are we hearing that there are any requirements coming out for testing all residents and staff?
Yes, I'm going to hold that question though until the next section when I talk about the dilemma around testing. But yes, we're hearing quite a bit about testing, even though there's a lot of gaps and issues coming forward, but I will take care of that in the next section.
Okay. Did I hear you correctly that AFC and HFA must have a dedicated unit?
According to the 2020-50, which technically is still in effect, nursing homes must have dedicated units, but you're only supposed to serve COVID positive patients in any other setting if you have a dedicated unit. However, in practice, that's not true because when this was first issued about a month ago, there were no places to put these patients other than where they were. The hospitals would not take them back. The regional units were not set up. And a lot of facilities did not have dedicated units either. So that's why the kind of mess continues. To my knowledge, the expectation is that nursing homes have dedicated units. And 2020-50 will tell you that if you don't have a dedicated unit, you can't take care of the resident, but we know in practice that's not the case.
Okay. Wasn't a lot of 2020-50 placed on pause by MDHHS?
Yes. However, that was from what we heard in a meeting and in an emergency order that came out from Robert Gordon. However, recent conversations kind of imply. Can everyone hear me?
Yeah, it sounded like you cut out just for a second, but you're good now.
Okay, so their conversations recently have kind of implied, and these are not, I'm sorry, these are not conversations, these are more like presentations, have kind of implied that everyone's moving forward with dedicated units, although there's been no guidance out. And I heard this morning during our testing call, again, I'll talk more about that in a little bit. I heard that Laura is citing any facility that doesn't have some sort of plan to serve COVID in their facility, whether they feel they have the resources, staffing, and the structural ability to isolate these people well. So again, this is another point of, I think, confusion and to some degree conflict. And we have let the department know and the legislator know on several levels that we feel that we're putting our residents at risk because we don't have clear guidance and a good plan for isolating these patients.
Okay. Can the hubs direct admit positive residents from HFAs and AFCs?
My understanding is that they should be able to, yes. I don't know in practice if that's happened. My understanding is that the regional hubs right now have about 400 beds available across the state. Of course, you don't know where those are. And I think that they are working on increasing the number of regional hubs all the time. But I don't know if in practice that's happening.
Okay. It looks like that was the last question, so we can go ahead and move on if you'd like.
Okay, great. Let's do that. So we're going to turn to Laura Funch, who is going to discuss the findings from the most recent infection control surveys that we have access to. And I say that because the department has reported this week that they have done infection control surveys in 264 of our nursing facilities across the state, and yet you'll see that we do not have data for any of those publicly posted yet. CMS has reported that about 44% of all of the nursing facilities across the nation has also received an infection control survey. However, I'm going to turn this over to Laura now, who's going to discuss those findings.
Yes, thank you, Deanna, and good morning, everyone. So listening to Deanna and Dalton, I'm sitting here thinking all this stuff is going on. In the meantime, all this indecision, all this lack of guidance going on in the meantime, the surveyors are in the buildings and facilities are being cited, and being cited for things that perhaps maybe be a little bit out of the control. But anyways, that's just what I was thinking. So just to let you know, around the second week of March, nursing facilities began being subjected to these COVID-19 focus surveys. And during these surveys, surveyors were directed to focus their review on critical elements that were associated with the transmission of COVID. These elements included the implementation of a standard and transmission-based precautions, the delivery of resident care, the facility's ability for infection prevention and control standards, their policies, procedures, and the ability to implement the procedures, infection surveillance information, how they were managing visitor entry, the education, monitoring, and screening of staff in their buildings, as well as staffing in emergencies. Next slide, please. So this slide just represents, as Deanna said, 39 of the surveys that I reviewed that were downloaded into the public portal between the dates of 4/7 and 5/8. They're all provider types by ownership were included in these 39 surveys, and the surveys were conducted across the entire state. Only 17 of these surveys were cited, and the 17 surveys had common deficient practices. The severity and scope of deficient practices levels range between an E, which is at a pattern level, all the way up to L, which is an immediate jeopardy level that's widespread. And I believe 5 of them actually resulted in that. So let me just also say, most of the citations that did fall within the scope of widespread, which would indicate whether that the facility had either multiple residents involved and or that there were system-wide issues that probably would involve a lack of education, the policy development, implementation of appropriate practices, most specifically such as hand hygiene, surveys that, PPE screening and social distancing. I don't know if anybody had a chance to listen to a stakeholder call just a couple of days ago with Seema Verma, but she also stated the same findings that I found in these surveys, that across the country, surveys are finding the same types of findings. And again, just as a point of reference, citations at F80 has historically been one of the most frequently cited citation across the country prior to the COVID pandemic. Next slide, please. So the following 3 slides here real quickly will reflect some issues that I found in these survey findings. And this has to do with the standard and transmission-based precautions as well as education. Real quickly, for instance, surveys found multiple staff members, from registered staff nurses to the housekeeping to the aides, throughout their facilities were not properly wearing face masks. Masks were found worn below their nose or above their chin, or and not properly being applied to. Staff were seen multiple times touching the front of their masks with their bare hands, pulling their masks off to speak, which I guess people can understand that they're hot, but after they do so, they fail to perform hand hygiene. Interviews with folks such as the infection control nurse also verified that their staff wasn't properly wearing the PPEs. And at the same time, this interview, their own mask wasn't properly applied. An interview with a nursing home administrator, they confirmed that their facility hadn't demonstrated or had demonstrated competence of their staff in wearing the masks as probably one would expect that they do. Sometimes, as in the surveys, through observations with the leadership of the nursing there, folks not wearing their masks correctly, the leadership was not correcting the staff member at that time, so they weren't providing on-the-spot education either. Next slide. So in addition to the issue of not implementing appropriate precautions, this slide represents the facility failure for active monitoring and or surveillance of infection control practices. So as staff were not seen wearing a protective gown, apparently a SENA was seen not wearing one, was asked about it, and sort of had a flippant reply in that she knew that she wasn't wearing one and she knew that she was supposed to, and kind of added, well, I didn't do it yesterday either, and just kind of nonchalantly went about her business. At another survey, a resident's door had indicated they were supposed to use contact precautions. The sign was posted on the door, which was what was the right thing to do. But upon entering to the room, there was no dedicated non-critical equipment such as the blood pressure, the thermometer, oxygen. And then the staff, also confirmed, yep, it's not in there, and, didn't take any actions to rectify the situation to demonstrate that they were to fix it. So, it kind of leaves a person with the impression that I don't know, maybe it was just feared them during the middle of the survey, but it would have been probably a better thing if they could have witnessed action being taken. Next slide, please. Another survey found failures to ensure the appropriate isolation of residents in droplet isolation for COVID. And again, as well as they failed to take actions to prevent the spread. At a facility, a resident was readmitted into one of their facilities with a diagnosis of COVID. He also had some other comorbidities such as chronic or COPD and severe end-stage renal dialysis. A review of the medical record indicated that there was physician orders for droplet precautions, but it wasn't implemented until 6 days after that resident had arrived at the facility. And this resident was admitted into a occupied semi-private room. There was another resident in there. So that is concerning. In addition, the facility's assistant DON, who also functioned as the infection control nurse and the education nurse, provided that there were 16 other residents in that building that was supposedly placed on prophylactic isolation, but for only 3 days. When they were questioned as to the length of the time, they indicated it was a corporate decision and that the residence was removed out of any type of protective precautions after 3 days. I don't know how to explain that one, but they were cited for it. And I believe this is one of the facilities that got the immediate jeopardy at the widespread level. At the same facility, a resident that was exposed to a roommate with a COVID was observed rolling themselves around the hallway throughout the unit into other residents' rooms, accessing that resident's bathroom. That person also didn't have any protective covering over their mouth or whatever. and nursing staff observed it and took no action. So that is a concern. So it's in a couple of these scenarios, it's not that the facility didn't have a policy, is that the facility either lacked the monitoring to ensure the actually lacked the monitoring to ensure that the practices were being performed as their policy and as standards of practice dictate. Next slide, please. This next slide kind of reflects that a survey finding where was that this facility did not develop and effectively educate staff on policies and procedures regarding updates to prevent the COVID-19 infection. Their facility policy did not address pandemic situations or measures that would need to be implemented that would extend or the reuse of appropriate PPE in the event there was a shortage or delay in receiving appropriate recommended PPE. Interview with a staff member there reported that she was not specifically educated about additional signs and symptoms of COVID, such as the recent loss of taste or smell. A hospice nurse there that was working there reported that she too hadn't been made aware of CDC guidance related to the additional signs and symptoms, and that should be documented upon screening when entering to the facility. So I know there's lots of guidance to keep up with, and I know that Leading Age has been doing, in my opinion, a really fine job in trying to help keep everybody up to date with it. But it's just constant vigilance that it's difficult, but we have to keep up with them because facilities obviously are being cited. At another facility, this has to do with resident care. A resident vital signs began to decline. Their blood pressure was decreasing. Their heart rate was going up. Their O2 sats were going down. This is recorded like in the early morning vitals, but there were no additional vitals that were documented for the rest of that day. It didn't appear that the facility staff took any action on that. There was no reassessment, no additional monitoring, or no notification of the physician until the next morning, at which time the doctor gave her orders to send that resident to the hospital where he later died. So is that an education thing? I don't know, but it certainly is a resident care delivery issue. Often surveys are being found with findings that it's associated with hand hygiene, and hand hygiene has been one of the most frequently cited reason for being cited for infection control practices, and it's the single most important practice that can reduce the transmission of an infectious agent. At one survey, an observation was made both while the infection preventionist and the director nurse was standing there, where the SENA was incorrectly performing hand hygiene with hand sanitizers. Neither the infection perfectionist or the DON gave spot-on direction or redirection on appropriate cleaning. There was no action taken. Further review, when the surveyors look at data and looking at quality monitoring and whatnot, their own quality tracking for competency and whatnot indicated that one of the measures is for a 15-second rub, where the guidance says there should be a 20-second rub. So their own facility weren't kept up to date or weren't following appropriate guidance for hand hygiene. This next slide, please, reflects problems with the COVID visitor screening process. At a facility, observed the staff screener was repeatedly told by their own facility administration that they had to keep the people coming in keep them at a 6-foot distance. It had to repeatedly remind them of that need. Staff members and visitors were seen coming in and exiting at the same time. And this screener didn't provide any instructions to keep the 6-foot personal separation. In addition, a staff member who also entered the facility without any social distancing was also not screened upon entrance, didn't answer the questions, just was allowed to access without answering those questions. At other survey findings in other facilities, similar issues were found. Folks were granted access without completing the screening form. Some of the sign-in sheets revealed that staff was documenting elevated temperatures, cough over many days, along with having close proximity with ill members, and still allowed to come into work. Administration was saying that they weren't even reviewing the sheets until after a week or whatever. Well, at that time, folks are already in the facility and potentially exposing the environment. So that is an issue. So, and again, along the same line, folks weren't keeping the social distancing during a lunch observation. There was more than 10 folks in the building or in that room, and they weren't being separated by the 6 foot. And then on interview, staff said they weren't sure why that was even needed. So again, there's an example of a lack of education. Next slide, please. This next slide represents an issue that in terms of non-critical medical equipment being cleaned or disinfected. An RN was observed using the vital sign after completion, didn't clean it as their policy indicated. Interview with the same nurse reported that it was cleaned only if a resident was in isolation precautions. In the same unit, another CNA through this interview thought it was only done a couple times a shift. So again, a lack of education, or perhaps even, again, perhaps it's just a lack of consistent or constant monitoring for appropriate infection control practices. And along the same line, this has to do with a meal delivery, where meal delivery was done via a cart using the reusable meal trays. The cart was returned to the kitchen, but through the interview and a record review with the dietary manager, they found out they were using a desanitizer that wasn't approved against the use for COVID. So they weren't adequate cleaning their own equipment. So again, so that's just another thing that folks need to pay attention to on making sure that their disinfectants and their processes, even when it comes to mixing the adequate ratios for disinfectant with water, is per the manufacturer's recommendations. Next slide, please. Two other issues that were identified has to do with, one of them has to do with the use of their surveillance data. In this particular facility, actually there was 2 facilities where nursing leadership, number one, lacked the knowledge of what surveillance data even needed to be gathered. And number 2, hadn't collected data for months. And this is going back to maybe 1st of January. The data hadn't been collected. The infection control nurse wasn't aware of it. They weren't looking at the data. They weren't trending. They weren't summarizing. And this is a facility that had probably immediate jeopardy at the widespread level. They didn't know what was in the building, and they certainly weren't taking any actions during this pandemic to prevent any spread. Next slide, please. And finally, this last slide right here reflects the issues with the policy for staffing in emergency. This particular policy, our facility, their policy did not outline any specific delegation of duties or a directive that would support or maintain staffing that's designed to care for staff with a contagious, with COVID on an isolation unit in an effort to reduce cross-contamination. So this kind of talks about consistent staffing and not having staff float around to other care areas and potentially spreading the environment. Next slide, please. So I guess the key messages that I would share in terms of the takeaways from these survey findings is bulleted here. Do your best to please keep up with the very frequent changes both in CDC and CMS guidance. Make sure your staff have been educated to all these changes and provide constant re-education. Remain vigilant regarding the monitoring of all your staff infection control practices, right from the administration through direct care delivery, through your support staff, your housekeeping, your dietary, your maintenance man. It's constant watching. Pay attention to your surveillance data, record your data, and please document any actions that need to be taken. Document your findings. You know, use your QAPI process and document your findings and be able to show actions that you're taking, and then monitor for those actions to see if it had an effect. Hopefully it had an effect on your outcomes. Make sure you're watching your registration numbers on your supplies to see that they're appropriate for for COVID. Make decisions regarding your resident placement on a case-by-case basis and consider all the risk factors to your other residents in terms of room selection and available alternatives. Limit the transport and movement of your residents outside of the room to medically necessary purposes. And as much as you can, try to utilize consistent staffing models as much as you can. That is an environmental control factor that is demonstrated to have a positive effect. Next slide, please.
Laura, I'm going to
I would
interrupt
ask
here.
if you have any questions.
Laura, we're running
Yes,
so far
ma'am.
behind that I'm thinking let's hold your questions until the end. We have some really important updates that we have to get to. I apologize. Thank you so much for that summary. And I would like to move on to Michigan updates. I think that there are a lot of some of the smaller updates that I've listed here, but there are some really critical issues such as testing that I want to get to. So I will go through some of these pieces very, very quickly, but you will get the resources for these pieces in the Q&A later. There are two things that the department has done in order to supposedly help staffing issues. One is the healthcare jobs portal, and the other is the department volunteer staffing list. Information about the portal is here. Some people have used it before. It was recently identified just for COVID healthcare issues as a subsection of a larger portal. The MDHHS volunteer staffing list actually has thousands of people on it, and that will be used supposedly as the department's response to what happens if you have a lot of employees who are asymptomatic and test positive. We actually don't think that that's the best solution, and the department understands that. They are considering some other issues, but they do not have a good answer for that. However, there is a volunteer staffing list available, and the SurveyMonkey site here is a request to use those. So we can move on. Decontaminating N95 respirators. There is a lab in Detroit who can do this free of charge. The website is here. Further information, we'll make sure that you have access to it. MDHHS reporting. We do know that they sent out a memo on 5/14 supporting the CMS and CDC SNF reporting, and those are the reporting requirements that were identified in 2029. Right now, SNFs continue to be the only Michigan entity reporting to the CDC, and their reporting is through EM Resource. In getting enrolled and listening to CDC guidance on these pieces, there has been a little bit of confusion because the CDC will talk about assisted living entities entering information, but that is not for Michigan. And they also will talk about back reporting, and that they're requesting some people to do back reporting back to January. However, SNFs in Michigan are not required to do that, and they only have to provide case information as of 5/8. The other thing before we move on is that the department is renovating or revising EM Resource to make sure that the measures align completely with the CDC definitions for those measures. And eventually, they're hoping that if you put your data into EM Resource, that the department can immediately upload it into the CDC. However, that's down the road. Financial assistance for telecommunications. The CMP fund request for application for the state of Michigan these are the links here. Those links will also be in our Q&A. The rules for this are under QSO 2028. And there is a separate telehealth program that can be funded by the CARES Act through the FCC. They have a total of $20 million in funding. You have to be a not-for-profit, a public entity, and it does include skilled nursing facilities. So if you are looking at expanding it or starting a telehealth program in your facility, this could be helpful. Okay, Laura, there's really only, I think, one basic Laura update. Move forward, please, Blake. Basically, there's a string of executive orders that continued earlier guidelines, the temporary licenses for CNAs, the ability to expand your bed capacity and change your bed designations, using Medicare beds for Medicaid patients, etc. All of those were simply extended. Executive orders, I'm not going to go through these at all. Last night, the governor put out 3 more. It's only 82 and 84 that are in the recent week that are pertinent to long-term care, and they were both 100% extensions. In other words, there's nothing new in any of these. Testing, okay. So the department has put together a work group that includes, at this point, a representative from the local health department, the Michigan State Police, the IPRAT teams, public health, MD, HHS, and a couple provider associations to talk about how they're going to move forward on this testing plan. And there is a testing plan for Michigan. The goal is for 100% testing of staff and residents, mostly residents, but also staff. And that is in alignment with the White House recommendation that came out this week that all nursing homes undergo COVID testing, although there is no mandatory rule out there anywhere. So the governor's goal is to increase overall testing to 30,000 per day. Right now we're at 12,000. We just got funds through the CARES Act for over $300 million to support this testing. The CDC has listed testing priorities, and Michigan follows that, but now wants 100% testing. And they're debating about how to phase that in. Move the slide forward, please, Blake. The thing about testing, and the thing that has been of concern is what about resident rights? What about your staff rights? Can they make you do this? What are you going to do if indeed you find you have a lot of asymptomatic staff who might test positive? How are you going to deal with that? So the goal here, and we have brought up these questions time and time again to the work group and to the department. The answer is they do not have the ability to mandate testing at this point. Unless the department and the governor come out with some sort of direct order, they cannot make anyone test. However, because of the public health emergency, they're going to strongly encourage that you test. And if there are barriers to those, to testing, the IPRAT team and the local health department is going to try and work to make things happen. One of the issues is that if you find you have a lot of COVID patients and you're not really prepared for that, where are they going to go? As we said before, there are regional hubs that have 400 bed capacity right now, but 400 beds across the state we know is not very much. Part of the goal now, apparently this was decided last night, is to move forward with testing ASAP. And the reason why they're doing that is because that they have limited access to the National Guard teams. The National Guards, working with the local health departments and the Michigan State Police and the IPRAT teams, and they're all kind of working together to figure out how to get testing done in as many facilities as they can. It's kind of a phased approach, but it's a very rapid phased approach. This morning we were told that they've identified 10 areas in southern Michigan, now that they've finished the upper, that they want to start with. And those are Oakland, Wayne, Macomb, Genesee, Saginaw, Ingham, Kent, Muskegon, Washtenaw, and they've separated out Detroit, even though Detroit has already done 100% testing once. So I will include these counties in our Q&A so that to make sure that you have them, but pretty much it focuses on your higher population areas, and that's where COVID tends to be largest. So if you're in Southeast Michigan, I think that you can plan on hearing from some of these teams as they move forward. I think it's usually the state police or the local health department that will contact you first. We have asked numerous times, and the department says they are going to do this, that they give you an update. They give you a heads up. They send out a directive or at least some sort of memorandum that tells you what to expect, tells you what the process is, and tells you what the goals are, so that everybody just doesn't have the state police or the National Guard at their front door all of a sudden. So they have promised to do that this time. I don't believe they did that in the upper, and I think there was a lot of concern when the National Guard just all of a sudden showed up at some of these facilities. So we have worked really hard to try and communicate with the department about what we think some of the issues are around here. Some of the teams, such as the IPRAT team and the public health team, want the state to make this mandatory. However, the state has chosen at this point not to do that. I think that if there were a lot of residents who refuse to be tested, then they might look at that again. Everything is very fluid and everything is kind of evolving on a day-to-day basis. It's really, I hate to say this, kind of messy. And I feel bad lots of times because I don't have good answers for you. But I want to assure you that we are telling the department what we think about all of these issues as this pandemic moves forward. Okay, so next slide, please, Blake. So I threw in a couple of the governor's slides just to give you some background. These are her slides from one of her press conferences earlier in the week. This is her testing strategy. Again, she wants to go to 30,000 by June, a day, 30,000 tests per day, including nursing home people. Keep going. This slide will show that she has a targeted focus on testing in nursing homes in the UP, and they just finished in the last week, I believe, up there. They are again moving down to the lower peninsula, I believe next week. So some facilities could hear very soon from this group. Next slide. This just shows you how much testing Michigan has done and compared to other states. And we have like 10, we're number 10 in terms of population. We're number 6 in the total raw number of overall tests, but per million population, we rank about 15. So, but there is a huge push in Michigan because the governor feels that until she knows the real extent of COVID, we can't fully move forward in opening all the businesses. So very quickly, some CMS and CDC updates, and I will not spend a lot of time on this. CMS put out a list of all of their 1135 waivers and their flexibilities. That list is at the link in the bottom. Remember, your links will not work from the PowerPoint. We will put them in the Q&A. I won't go through this page. This is just the things that had been done to date. In fact, the next 4 slides are just the waivers and some of the flexibilities that CMS has done to date. So I will go rapidly through them, and then we will get to the ones that are new. So move forward, please, Blake. Physical environment, we do know that scheduled inspections have been canceled for most things, but they have a list here of things that you cannot cancel your scheduled inspection, testing, and maintenance plans for. Sprinkler systems, a lot of fire and emergency generator issues here. So be sure that you understand which ones you can, which inspection requirements you can ignore and which ones you can't. These flexibilities, again, are not new. These have to do with physician delegation, physician visits, the 4-month rule for CNAs. They still must be competent. Those are not new. These are also not new, talking about transferring ability if you need to cohort residents, care plans, and notification issues. Again, although they put out this whole thing, these pieces are not new. What is new is to allow hospitals to establish SNF swing beds payable under the SNF PPS if areas cannot find a SNF COVID bed. They have to be designated specifically for SNF care. They cannot be used at the same time for acute care, and they have to have exhausted all their other options to place this person. One of the things that came out in the last week that's new is a modification of the required length of time for training programs for paid feeding assistants. I don't know how many members might be trying to use paid feeding assistants. They might have started to use them during the pandemic. However, technically the guidance says that you really only have to train for 1 hour, although you do have to include all of the content that you would have in 8 hours. In other words, you have to cover all of the same topics. However, this is something that is also governed by the state. So right now, Laura has not put out any guidance that we can do this. So right now, this does not apply to Michigan. Life safety code, there were some additional changes to the requirements for life safety code, placement of alcohol-based hand rub dispensers. They're obviously aware that you need more than normal. You still have to store them in the same way, but you're allowed to place them beyond the current rules for placement in the facility. Instead of quarterly fire drills, you have to provide an education and orientation kind of program that reviews the current fire plan, everyone's current duties, the life safety procedures, etc., with old and new staff. And last, under this piece, CMS also has waived the requirement that prohibits temporary walls and barriers between patients, obviously, during the pandemic. CDC has put out some new guidance. A lot of the CDC new guidance has an awful lot of old guidance in it. So it's really kind of hard to figure out how important some of these are. There are considerations for memory care units and long-term care facilities. There's some good guidelines there. There's no real rules in there, but it is a helpful tool if you are struggling with memory care during the pandemic. Responding to COVID, same kind of thing. A lot of things that you will find in any other, in many of the other web pages under the CDC, but kind of put all together to discuss all of the issues with cohorting. And last, they put some additions to the interim additional guidance for infection prevention and control with suspected or confirmed COVID. I reviewed that. I didn't see anything really new there. However, these are things that you might want to look through. And in fact, I think it's always a good idea to re-review some of these things as we move forward, because although they don't necessarily, some of them change, some of them don't, but it helps to remind us what we need to be doing. CDC framework for non-COVID care. That's something that they put out on May 12. It really talks about people who don't need COVID care and the fact that CMS and CDC are very worried about the fact that important medical services are not being provided. So there's a grid and a framework here that identifies the kinds of things that a patient might need and how to think about whether or not you need to move forward and get that care at this time. Nursing Home Commission. Apparently the White House Nursing Home Commission that was discussed and established in the last few weeks is they're working with a contractor to set up this commission, and they're accepting nominations from the commission, from the industry. So anybody who would like to apply for this commission, that is the website to do that, and we will also put that in the Q&A. I would hope that they have a lot of input from the industry professionals. I think that they really need that here. So I'm sorry to have gone through that so quick. I know that we've spent a lot of time today. I apologize for that. And I also feel like, as I said before, we don't have a lot of good answers to a lot of questions, and that's really a sad place to be. But we do keep working with the department and pushing them in certain areas to try and get some maybe better coherent and communicated principles and guidance forward. So with that, we will take final questions.
All right, I have a couple questions. So the first one, per Jay Kellerwert's update on Tuesday, AFC's HFAs could not direct admit to a regional hub, only hospitals and nursing homes could. Can we get clarification on this?
You know, I apologize. I do believe that that is correct. But I guess I would still want to go ahead and push the department on some guidance about how AFCs and HFAs are supposed to care for these consumers who have high care needs, and in the kinds of facilities that really, as far as I know, are generally just not prepared to serve patients with this kind of infection. So I do apologize. I do believe I remember that that is the most recent guidance. But I will continue to talk to the department about what we're supposed to do especially if COVID starts to really increase in those settings.
Okay. Is there a possibility of a repeat IP survey if you've already had one?
I don't know. Laura, can you take that, or do you have any knowledge about that?
I do not have direct knowledge that it is a yes, but I would suspect that it might be, since recent guidance indicated that they were going to be looking at 2 additional tags, the 884 and 885. So with that assumption, I would say probable.
Well, and not only that, with all of the focus on nursing homes and long-term care settings, the QIOs are now involved. In fact, I think in the last week, the QIOs have been charged with and have gotten funding to also provide assistance, although I think it's virtual assistance, but to work with facilities in their self-assessment, figuring out what resources they need. I think the focus is so targeted on nursing homes right now that I wouldn't be surprised that you didn't have a lot of unfortunately, a lot of oversight from numerous agencies.
Okay. We did have someone comment in and say that they know that there are second surveys happening.
Oh, okay. All right,
Uh,
good.
All right. Any update about the Michigan Senate bill $3 an hour payment for frontline workers? Is there funding for that coming?
Unless I'm mistaken, I believe you're talking about a $2 an hour payment for Medicaid workers. That is currently only for in-home workers who are covered under My Health, Link, My Choice, adult home help, and behavioral health. In talking with the department and responding from them, I don't hear that there's any right now inclination to expand that to residential settings. If indeed I do understand what the question was about.
Okay.
I have something to add as well. There was recently a pretty politically charged supplemental passed by Senate Appropriations that did increase that $2 to a $3 an hour increase.
Oh, okay.
Just so you're aware, but it was fairly political, so the chances of anything getting done with that supplemental are pretty low.
Okay, well, thank you for that, Dalton. And do you know if the way it's written right now that would include residential settings?
I do not know, but I believe it is written the exact same way the governor intended, so it would not include, but I haven't read the exact wording yet.
Okay, thank you.
All right. Somebody did again chime in and said contact your Medicaid waiver agencies on this. We're receiving guidance from our agencies that we will be getting additional funding to our per diem reimbursement rates. And then somebody else said
Wow.
Senate Bill 690.
Wow, okay.
And then
Well, that's good information.
another one just came in and said, I just signed agreements with Area Agency on Aging of West Michigan and Reliant CCP in Kent County that we do qualify and we are an HFA.
Good. Okay. Well, that's good to know. I wasn't aware that was happening.
All right. Any update on the Q&A? How does our organization estimate lost revenues for submitting to HHS? In particular, which lines of business that should be included in that amount?
Well, that's a very complicated question, and I would have to refer that. I do know that lost revenues are allowed to be included. In fact, I think that they're going to be a large part of the cost base for your grants and et cetera. But let us find some resources for you because I personally am not a money person.
All right, and then looks like this is going to be the last question, and it's not a question, it's more of a comment. So they said, I heard on a call with Region 6 yesterday that the state fire marshal is not recognizing CMS's waiver of temporary walls blocking egresses. Not sure if this was SNF or HFA, but seems to be some tension in Michigan that needs to be resolved.
Okay, we will look at that in our Q&A and see how we can follow up. Okay, well, thank you, everyone. Again, I know that this is a very messy situation, and I appreciate your tolerance and your patience as we move forward, and specifically your dedication to our seniors every day. If you have any other comments, questions, please submit them. You can also submit them, if you move the slide forward, Blake, to our Safe and Calm dedicated email address, and all three of our email addresses are here. We do try to respond as quickly as we can, and we will, if we don't know the answer, and there's so many things, we obviously can't know the answer to everything, we will try our darndest to help. With that, thank you, everyone, and have a good weekend.